So we've really looked at this point just the key factors involved in single tooth management. And I think the important thing to realize is that those principles really apply to all the scenarios that we work with, whether we're working with immediate or delayed. In other words, those principles of establishing stable contours and the correct position of the implant, the soft tissue, and the details of how we do things might differ between an immediate and a delayed case, but nevertheless the principles, what we want to achieve, are the same. And those key steps apply in all these cases, and indeed in multiple tooth replacements too. And there are some important differences, obviously. And as we know that from the literature, we know that in a heel ridge, the maintenance of the bone and the papilla between implants is not the same as between teeth or between teeth and implants. And we can't get the same soft tissue scalloping or architecture. And we know that this is a limitation that's been well described by many. As you can see here, the middle papilla between the centrals is deficient compared to the papilla between the teeth and the implants. But nevertheless, it's an adequate result when we understand these limitations. But when we come to multiple implant restorations, we have to look at what we're comparing against. We look at this patient here as a patient with restorations on natural teeth, and you can see a 6-year follow-up of, in this case, ceramic veneers. We can see that we get very nice biologic integration and maintenance and stability of the tissues, and really that's what we're dealing with when we're facing our implant restorations today, that we have to match up to the results that are achievable on natural teeth. Another example, patient with somewhat compromised teeth, of course, and you can see that we can effectively restore these patients with restorations on teeth, crowns, veneers, and so on, all these different things that are in our armamentarium, and we can get very stable and adequate results with these types of restorations. But the thing is that we have a good foundation to work with. The soft tissue architecture and bone is sound, and often that's just not what we're facing when we come to multiple tooth replacements, because our large cases are generally compromised patients, and this is what we commonly see. And this is an interesting case because we see a patient here with a broken down dentition and mouth, obviously, that needs some significant work. And you can see that the patient's had a lot of dentistry over the years, and that's now failing, and this is a common story. Indeed, if we look at it, we can see that the mandibular teeth are probably restorable with conventional restorative, with fixed prosthodontics of some kind, whereas the maxillary teeth, which you can't see from the photograph, of course, but are all failing. They are, the crowns are all loose, the teeth are hypermobile, there's infection and all sorts of problems around these teeth, and they basically need to be extracted. And we can see also that this is a challenging case for many other aspects. There's been some periodontal history, there's been loss of volume of bone and tissue, we see very large pneumatized sinuses, so it's not an easy situation. If we look at the patient with greater details, we can start to think about, well, what are some of the considerations and options for the patient like this? Because when we look at this patient, we have to think about, well, what is the intended goal? What are we trying to achieve for this patient? What is the history and the patient factors might influence our choice of treatments and our management of the case? What are the prosthetic options? Well, a patient like this, what could we do? Well, if we extract these teeth, we could allow things to heal. We've got then option 7 where we could, are we going to do a fixed? Are we going to do removable? Are we doing all on 4, all on 6, all on 8? Are we doing bridge work? Are we doing one piece? There are many options to consider. Do we have space, interarch space, in order to do an all on 4 adequately? How are we going to manage the occlusion when we have a natural tooth fixed restoration in the mandible versus a maxillary implant supported restoration? Are we going to use it metal acrylic? Is that wise? Is it stable? There are many questions that we have to ask. If we do typical all on 4, we have to reduce the ridge in order to create interarch space for the thickness of the material, otherwise they continue to fracture. The other problem that we have, and nobody really talks about this, is managing the hygiene and phonetics. Obviously, you have a one-piece maxillary reconstruction with an all on 4 and all on 6. Nobody really talks about the long-term implications of such, because in the maxilla, to create that with maybe a guided surgery or other surgeries today, we have the problem of concave areas, of ridge lapping, how does a patient clean that effectively over time? Certainly in my hands, in my practice, we've seen much more complications around that type of design than if we use a crown and bridge type approach where we try and produce restorations which are much more maintainable. We'll talk a bit more about that in a second. There are anatomic considerations. This patient has huge sinuses, very little bone. This may be an issue. There are advantages and limitations of all these different approaches that we've discussed, and of course, the patient's budget is always an issue, and that needs to be discussed. So, this is an interesting case. Let's look at some of the considerations here. So, when we have large cases, we have some cases in Misch's classification of where we have FP1, which is basically just replacing the crown. Then we go to cases where we've lost some of the root coverage or tissues. We may be replacing both a bit of root, a bit of the tissue and the crown, or we may have those cases where we've had long-term edentulous where we're replacing a lot of the volume of tissues, bone, soft tissue and root surface. And generally we're working in these cases where first category we want to preserve as much as possible the tissues. Second category we try and convert it back to, reconstruct it back to an FP1, or we're going to have elongated teeth or prosthetic gingiva. And of course in the larger category we have long-term edentulous and we're going to have long teeth, prosthetic gingiva sure, or we may even consider removable options. I have to say in my practice that's not really very common. Practice patients don't really want to consider that, but of course that depends on the type of practice and your physician, the kind of patient client base you have. So let's go back to this patient now and consider what we're going to do. Well, it's an interesting case because we can retreat the mandible with conventional pros and the maxilla with implants. So let's look at the principles of what we do. And my principles are to try and achieve an outcome on our patients where with our crown and bridge work on implants that we can achieve essentially the same outcome as we could if we had had teeth that we would be able to maintain. Now obviously there is already a compromise in terms of what we can achieve because the patient has not a simple history. But you can see that in the maxilla, looking at the occlusal view, we have a similar sort of crown and bridge view compared to the mandible, and the maxilla is on implants, the mandible on teeth. Let's look at it a little bit more closely. We see some hyper-contoured teeth, slightly broader than we normally have in order to close down the black holes, but we have a hygienic design of prosthesis here. What we've done is we've created a sufficient augmentation of the buccal volume of the ridge as much as possible so that we can create a natural emergence profile and have ovate pontic designs so that the patient has a cleansable design of prosthesis. And we like to do this not in one piece but in small units, rather like crown and bridge work on teeth, because this is easier for us to fabricate and maintain. See, our concern is when we look at the literature and we can see what the literature looks at, systematic reviews and so on. This group, the EAO, the EAO group looked at a systematic review of complications with fixed partial dentures. They found that only 60% of the patients were complication-free. In other words, 40% of patients have some complications, and the majority of those complications were indeed prosthetic ones. In other words, fracture of veneering materials. We see this a lot with acrylic, metal acrylic. We see fracture of veneering materials, or delamination, or indeed screw loosening and things like this. And then there was a small percentage of biologic complications which we're all going to face. Peri-implantitis is a reality. We don't really understand it yet and understand the whys and wherefores, but it's there, and we know that if you've not seen it, you just haven't done enough implants. So in my practice though, in a private practice, to have 40% of my patients coming back for revision, repair, it's just not financially viable. So we need to have protocols that give us greater predictability. And this may mean at the start of the treatment doing some further steps, maybe making a slight decision to go with a more complex treatment in order to make the long-term stability simpler. And you'll see it's rather like crown and bridge work. There are rather more implants than we probably would need. To be honest, we would probably use 8 implants in a maxilla, and we typically place the implants in the first molar, first premolar, canine, central incisor region, perhaps maybe in a second molar or second premolar. And if the patient has poor quality bone and has the budget, gives us some flexibility, we may put in a couple of extra ones, maybe up to 10 implants in a maxilla. But usually 8 is ideal, sometimes 6 can be fine too. But as you can see, that it's rather like crown and bridge on teeth. Now, In this case, we've got 3-unit bridge, single unit, and another 3-unit, another 3-unit, and then 3 single teeth. Probably today we would probably do this with 4 bridges and splint the 3 distal implants and have 2 3-unit bridges in the anterior and a 3-unit on the left-hand side as well. Just simpler rather than using single units in all those cases. But essentially, the principle is to create a design that the patient can maintain easily. And what's interesting, it's pretty similar to what we have in the mandible, because we don't really have any conclusive evidence that says that we should do a one-piece framework. In fact, it's very little. It's just the way that everyone's done it. There isn't really good evidence to say that that is better or correct over and above split units. And the advantage of doing smaller units, of course, is that we can fabricate them easily in the lab. They're easy to fabricate passively, and they're easy to repair and manage if anything breaks. But of course, because there's less stress built up into of smaller units, rather than trying to do a 12-unit, say, PFM restoration, which has a lot of stress and difficulty in creating that across the arch in a curve and having a passive fit and having it stress-free, we see more cracks and fractures and those sorts of problems. We see less ongoing problems in maintenance. So when we look at the same patient now after 8 years, we see that things look pretty stable, and particularly when we look at it clinically, in 9 years follow-up, we can see that we see a very stable soft tissue situation. Please note that there's no fractures of porcelain. We have a stable occlusion because we've obviously managed that very carefully, giving appropriate attention to detail there, having canine guidance, anterior guidance, disclosure, this posterior disclusion, having a shallow guidance as well, just respecting all the principles that we've learned all those years and studying occlusion and managing restorative cases, of course. And of course, in 9 years, we can see that we've had a very stable outcome. A little bit of soft tissue migration on one of the incisors, but after 9 years, that's not a big deal, and particularly in a case like this. So, and then we can see that we really can manage these cases well. What about a case like this? Well, it looks like a real horror story. But of course, you can manage these cases, and our goal is to try and achieve outcomes for these patients where they can stand the test of time. In the 7-year follow-up, we see that we managed to augment or basically create an architecture which is maintainable for the patient with a mixture of implant restorations and 2 supported restorations. And we have, at 7 years, 1 implant failing. The distal implant on the lower right mandible is failing from peri-implantitis. The patient is a heavy smoker and continues to smoke heavily, and that's just the reality of our patients today. However, if we can really put that into perspective, to lose 1 implant in 7 years in a case like this, it's not such a tragedy, and we really have achieved a successful outcome. What about more complex cases? How do we manage these cases? Well, our thinking is really, again, about maintenance and stability over time. Now, by all means, to do a single piece reconstruction is easier from a fabricating point of view, or manage a surgical point of view in a case like this, perhaps, and indeed a prosthetic point of view. But there are some disadvantages. How would you manage the contours and the concave contours, have the patient clean that effectively? So what we like to do is follow those same principles. In other words, we like to increase the buccal volume of our ridge. We aren't going to get a great vertical reconstruction, but we increase the buccal volume. Why? So that we can place our implants and create emergence contours of our restorations, which are cleansable. Have a look at this. We can create crown and bridge work on that same patient, having had teeth missing for 20 or 30 years. Aesthetically, it produces a reasonably good result, good lip support and all the rest of the parameters that we seek to achieve. And look at the 8-year follow-up. We have pink porcelain built into this, small units again, same sort of principles as before, and yet look at the stability of the tissues, the bone, and please note, in 8 years, not a single chip of fractured porcelain. We have stability, and we have ongoing maintenance of this case. And this really is what we want to achieve in these types of cases. We even employ these sorts of things, this type of approach for those complex cases, and this is a case where the sad patient, mid-30s, losing her teeth with aggressive periodontitis, and there aren't really any good solutions for patients like this. In this case, perhaps today we would have done it a little bit differently. We would have tried to preserve some more teeth, but we did a full restoration of the implants, and again, we see how we managed to reconstruct the soft tissues as best as possible to create cleansable outlines, and also how we, in these big cases, we skip the laterals. We don't put an implant in the laterals. We want to create a pontic there. It's easier to manage that soft tissue profile in those cases. And we don't put implants in the anterior mandible either. We just place them in the canines and do a 6-unit bridge. It's very simple to do. You see the 2-year follow-up again showing good results in this case. But that's not the common reality. In our practice, the common reality is that the majority of multiple cases we see are of partial edentulous cases where patients have bridge work or situations like this where bridge is failing and they don't want to have dentures, and the patient's been referred to us for implants. And we have to learn how to manage these circumstances, improve the soft tissues, as you can see here. Actually, if we go back a slide, we can see on the right side the loss of labial tissues around that right premolar, which is failing, and then we had to carry out all our surgical techniques appropriately, immediately provisionalize, keeping some teeth if possible. It's a complex case, the details of which we're not so important, but you can see how we have to come up with strategies that allow us to reproduce a decent architecture of soft tissue and meet the aesthetic and prosthetic demands for the patient. And you can see again a 2-year follow-up showing a good, stable aesthetic outcome, and how we've reconstructed the soft tissues adequately in all those areas. So our management of soft tissues and hard tissues really for multiple is about preservation, restoration or reconstruction or replacement in these cases. So we're going to spend the rest of the time just focusing on the first one, which is preservation. Obviously the restoration replacement we've seen, really my views on that. Obviously there are other approaches, all on 4, on 6 and so on, as we've discussed, and there are various advantages and limitations in all these techniques. And of course we have to use what is going to work best for our individual patient in those circumstances. But I want to take some time just to focus on this idea of preservation, because we have some opportunities with placing of implants into extraction sites, and maybe some advantages in doing that in failing teeth situations where there are multiple failing teeth. I refer you to a paper that I published in the European Journal of Aesthetic Dentistry, where we submitted 10 cases that we followed up for up to 7 years in this approach. And in fact, many of you who have seen me lecture will have heard we present this material for quite some time. But hopefully now we can try and give you some clear guidelines as to how this can work. Let's illustrate this with one of the first cases. And this is a case where we had 2 failing teeth, 2 central incisors in a patient where we have a slightly gummy smile. The teeth are a little bit short and square looking, not aesthetically ideal. Patient wanted to have an improved appearance. The crowns had been regularly de-cementing, and the general dentist had noticed some cracks in the teeth and had referred the patient to us for a solution. You can see from the radiograph that we have some radiolucencies on the tooth. There's some resorption of the tooth taking place, and so we've got a problem. Thankfully, it's not an acute infection. We have it's been referred early, and that's very helpful for us. If we analyze the case carefully, we see that we're going to need to maybe crown lengthen the central incisors to get the right proportions, because at the moment the gingival margins are more coronal to the laterals, and this of course is not as aesthetically pleasing. So the proportions need to be a little bit changed, and the 2 laterals have had some veneers done which are not terribly good, and we're going to try and revise this whole anterior area. So the details follow the same principles as what we've shown you before, placing the implants into the appropriate position, palatal, biomaterial in the gap, and soft tissue augmentation at the same time where we need it. Now in this case we don't want to do that because we want to allow for some recession to occur, so we want to deliberately contour the restorations to improve or increase the crown length. So we place our provisionals initially. In the middle slide is the provisional lap placement, and then we allow that to remodel and modify those and add contour until we finish up with the result you see on the right hand side, and we now have a more pleasing arrangement of teeth. And what's interesting to note is that the radiograph shows us that the bone interproximally between the implants has been maintained. All the defects have healed. If we look at the level of bone between the implant and tooth, it's the same between the 2 implants. In other words, there's been no change of that peak of bone between the implants. And what's interesting, if we look at the clinical picture, we see at 2 years follow-up, good maintenance of the architecture of the gingiva, and we see at 6 years follow-up, perfect maintenance of the architecture of gingiva and perfect maintenance of the bone peak between the implants. supposedly not supposed to happen when we look at the literature. So the literature is not always correct. However, we have to understand why. And I think probably in these sorts of cases it's because we are working with an immediate extraction site. That's not mucosa, we have gingiva, we have collagen network, perhaps the fibers that hold the fibers, the dentogingival fibers in the papillar area, which go between the papilla and the bone. If by supporting the papilla, perhaps we hold the bone. In other words, maybe there's a reciprocal relationship between bone and soft tissue. That tissue also influences bone, not just the other way around. We don't know, is the answer. Is it just a fluke? Is it just one case? Well, let's look at a more complex case. Here we can see again another case, and we see that this patient obviously has some significant restorative needs, but has 4 failing incisors. If we look at treatment options, what are they? Well, we could extract. Most people would extract the 4 teeth, probably wait 6 months, place 2 implants and do a bridge, maybe do some tidying up of the teeth as well. This patient was only going to have the anterior maxilla treated because of financial reasons. The rest of the treatment would have to wait. Would you extract and place 4 implants? I don't think anyone would do that. That would probably be considered the wrong treatment. We could make a conventional fixed bridge on the canines. That would probably be a possible outcome. Would you be able to maintain that gingival architecture doing that? Probably not. We'd get a shorter papilla and a flattening of the papillae, particularly the one between the 2 centrals, as you can see. Would you place 2 implants immediately into a bridge? Possibly. What about 4 implants? Would that help us? Well, traditionally people would say no, but our experience is somewhat different. We remove the teeth, follow the same protocols, place our implants, use our biomaterial in the gap. And in this case, this is one of the early cases that we did, we only did a connective tissue graft on the right central incisor, where previously there was a poor quality tissue and a bit of a fistula. We provisionalized the case with a shell provisional bridge, which is supported on the 2 canines, and is just sitting on healing abutments on the implant abutments. And of course, the soft tissues are supported with the contours of the provisional and the healing abutments. This is the comparison of the before and after. We see on the left side the case as it presented, thin biotype, poor quality tissue, scallop architecture of gingiva, a mess really. But look at the right central incisor where the quality of the tissue was poorest. There was a fistula and a little infection. Now it's the best quality where we did the connective tissue graft. Interestingly, if you compare that site to the others, they don't look as good. And so this is really, in our early experience, showed us that the connective tissue graft really plays a very important role. If we look at the patient now radiographically, immediately after the final crowns, you see the bone levels, and then 5 years later we see those little bone peaks between the implants still there. Very interesting. If we look at the 2.5-year follow-up, looks pretty good. Look at the case at 5 years. Very, very stable indeed. So we can see, I'm not sure that I could have achieved that kind of architecture with any other technique actually, whether placing 2 implants on a bridge or having a 6-unit bridge on the teeth, would have got that scalloped architecture and maintained that scalloping. Certainly we're not seeing a compromised result as we would expect according to some of the literature, and some speakers would tell us. Well, what about a more complex case? This case with periodontal history. Patient with teeth that have extruded and protruded, become unstable and mobile. The lip line shows a little bit of gum, and that helps us a little bit because the teeth have come forwards and also have come down a little bit. But we can see that we've lost a lot of bone around the maxillary teeth and the mandibular right-sided teeth. And so the maxillary teeth are all failing, and more or less, except for the 2 canines, which we found relatively short probing depths, and although they were mobile because of occlusive trauma, because everything else in the maxilla was very mobile indeed. So careful planning to anticipate some recession of tissue, because we had a slightly gummy smile, and when she smiled you could see the gingiva. We allow for some recession, and we're going to crown lengthen the canines at the same time. So controlling disease, removing the teeth, removing the granulation tissue. You can see the pocket lining epithelium in these sockets. We place the implants in the ideal position relative to the final gingival margins, supporting the tissues with our biomaterial and so on. In this case, we didn't do any soft tissue grafting because we knew that we were going to lose some height, but we had a thickish tissue, and we see the provisional restoration in place. That's interesting. If we look at the radiograph, we also did some work in the posterior and also the other areas of the mouth. Now the patient had to wait some time. It was about 18 months before she could come back. And interesting, we see about a millimetre or so recession, maybe a millimetre and a half recession on those healing abutments in that time, which we expected because of obviously the bone levels being higher because of the periodontal history. And yet we maintain a nice scalloped architecture of the tissue. The final abutments, these aren't even zirconia, these are older than that. This is a metal ceramic UCLA type abutments because that's all we had at that time. And the final result, and what's interesting to see, 4 individual crowns maintaining a very nice architecture of the papillae. If we look at the radiograph before and the radiograph after, you see improvement in the bone levels and stabilization of the case, and we see the case before and after in a smile, and we see how we really created a very nice outcome. It looks like we've not lost any tissue height. We have lost some tissue height because patient's teeth had extruded and protruded a little bit, and now she's also smiling more broadly in the right picture. But you see a very nice aesthetic outcome. We've been able to reposition the teeth more palatal, so as in doing so the incisal edge is maintained at the same level, and yet the clinical crown is being shortened slightly because of the illusion of coming back. Also drops the incisal edge, you can shorten the crown and keep the same appearance. So I hope you understand that. And so you see a nice outcome for this patient. And if we look at the close-up, we can see that the interdental bone peaks being maintained at 3 years follow-up. Now, unfortunately, this patient, we treated this patient some 9 years ago or so, but unfortunately this patient has passed away. She developed breast cancer shortly after this slide was taken, and it turned out to be fatal, and I wasn't able to follow her up any longer than that. So this brings us to really the final part of my presentations today, and really how we're going to use all this information to manage these complex interdisciplinary cases. And a patient like this shows not smiling properly because she's learnt to hide her smile, and she's a rather unfortunate case. She's had a history of periodontitis, and she's a patient that presented us with that situation there. In 1999, unfortunately, she went to a dentist who didn't diagnose a periodontal disease. She had orthodontic treatment carried out because her teeth had been drifting, and she hadn't had any periodontal treatment carried out. And some years later, you can see that she ended up with an extremely compromised situation. She was a litigation case, and here we are. She was referred to me to have a solution. And it's a difficult case because we have a unilateral defect. You can see on the anterior maxilla the bone loss is more one-sided. This is always going to be complicated. And we have a patient who's youngish, in her 30s, aggressive periodontitis, was a smoker, has given up now, and we have to come up with a solution. And it's going to be a difficult case to manage. Surgically, we may get a reasonable result if we extract those teeth and augment, but it's going to be challenging. I suspect we'd end up with some pink porcelain or prosthetic gingiva, and we've got some teeth in place, some teeth with relatively no loss of bone, others with. It's a really difficult case to manage. If you extract everything, you expect to see some very uneven bone loss and resorption. You'd have to then cut away more bone and tissue and for sure use a prosthetic gingiva, which is going to be complex for the patient to maintain long term. What would you like in your mouth is the question. Would you like to have your own bone and soft tissue regenerated or rebuilt to the correct profile so that you could have your own teeth more or less in the right place? Triangular tooth form, narrow roots, a real mess. If you look at the occlusal view, you can see the problems that we have. The teeth are very unstable, and we have problems all around. This is how she prevented, even with a lateral periodontal abscess on the right central incisor. So quite a challenge for us. So we have to look at the case carefully and think, well, what are our treatment options for a patient like this? It's rather difficult. What can we do? Well, what we like to do, we like to first of all look at what are the goals of the treatment. And the patient has to understand some of the limitations and discuss the treatment goals. But if the patient is motivated and we have the possibilities, we know that we have some possibilities to rebuild this bone, not with complex grafting techniques, but with orthodontic extrusion. In other words, orthodontics can be used to even to generate or even to create tissue for us. It's almost an engineering of tissue, natural engineering, and we know that's very stable. But we have to remove the infection. Of course, first thing we need to do is control disease, and then we're going to remove any inflammation, and we're going to regenerate tissues. And we can engineer soft and hard tissue with orthodontics to create ridges by lateral movements, but also by vertical movements to create volume of bone and soft tissue. And let's show you how we do this. For some reason, the patient wanted to have lingual braces, which is complicated in this case. I don't really understand why, considering how the teeth look, but anyway, there we are. And we had to work with appliances to extrude, and we extracted the hopeless teeth, obviously treated the periodontitis, removed the inflammation. You can see much healthier looking tissues, and we were able to do that carefully, and then we start to extrude. The orthodontist, and that's Laura Frost in the practice who works with me. We have a team of 5 dentists that work together, of course, and in an interdisciplinary team. And Laura was able to extrude these teeth successfully to a certain amount, and we needed to go further because obviously still the bone and the soft tissues were too apical. We extrude slowly over half or 1 millimeter a week, and we retain for at least the same length of time. Typically, this type of treatment would take probably 6 months to extrude, and we would retain for 6 months afterwards. And if we look at this case as we went along, we can see we've got so far, and then we really needed to take things further. So now we endodontically treated the teeth, we prepared the teeth, produced a provisional bridge, and we used magnets within the pontics and in the roots to extrude the teeth further. And we separate the magnets from the magnets in the bridge, and you can see the teeth are, make sure that they're facing the right way. The teeth will be attracted to each other, the magnets attracted to each other, and we gradually reduce the size of the magnets or shave off and allow for space, which then closes again. As we do so, the teeth erupt and the bone and soft tissues are brought down. And you can see that we eventually bring this situation where the gingival margins on the natural teeth were above the level of the canine, but now you can see that we've brought the gingival margins on the incisors coronal to the level of the canine. Now it's ready to follow our protocols, place our implants. We did 3 initially, and then we did the 4th one in a short time. Place our implants appropriately, place our biobone substitute, maintain volume, place our soft tissue grafts, under contour the components. In fact, in this case, we even customized them to create extra space for soft tissue. You can see us carrying out these steps here. And then we allow things to heal. We get to the point of our final impressions, provisionalized. We construct our zirconia abutments with the correct contours, make our crowns and bridges and so on. As you can see, our cord, when we're cementing our restorations, whether they're provisional or final, always placing cord to prevent ingress of cement into this area. And you can see the contours of a concave profile and even a little bit of platform shifting used in this case. Not that I think that is actually all that important. I think you've seen from some of the other cases that we get good results with no platform shifting, so I think this is something of a bit of a fad at the moment that I'm not sure is truly necessary. It's not the whole story, certainly. But certainly it helps to create that concave profile and that narrow interproximal profile. Look at the improvement in the soft tissue architecture for this patient. We saved some of the teeth, obviously, where we could, and you see the final restoration with the final crowns on the implants. If we look at it as we started, huge improvement for the patient. Patient is smiling more naturally now, and you can see the architecture of the tissue is much more acceptable. Not perfect, it's never going to be perfect in this case, but certainly very, very acceptable indeed. If we look at the before, just remember how we started, and look at the gain of volume of bone that we achieved in that area in the anterior maxilla. In fact, in stabilizing all the arch, we see health returned, nice bone levels, and a much more pleasing aesthetic outcome. And look at the 2-year follow-up, very, very stable and a maintained architecture of the tissue. So everything working very, very well. Our final case will be The same principles to a more complex and more extensive periodontal case. Again, patient looking for implant solution, fixed solution, really neglected her mouth, as you can see. And we have to consider, again, what our options are. If we extract everything, we're going to for sure need to use prosthetic gingiva. Is that a problem? Well, no, we can use it, but are there better alternatives? Is it easier for the patient to maintain long term if we had the soft tissues in the right place, as we showed in the last case, and a nice outcome for that patient? Well, if we look at the patient's smile and the radiographs, we can see some significant problems in this mouth, aggressive bone loss, and you can see that things are a real mess. Not a lot of bone left around those teeth, but can we use them nevertheless? Well, a close-up view for you to see the problems. First thing we do is remove the disease and the inflammation, stabilize the case and try and achieve a healthy starting point. Obviously cannot do orthodontics if we have inflammation. And then we're going to start to use the orthodontics to extrude and correct the splaying of the teeth, obviously, and start to extrude the roots down. We keep some of the teeth in the posterior as anchorage. We had the upper right maxillary second premolar was the only tooth with no pocketing and no bone loss, and so we used that predominantly as anchorage and kept the upper left posterior teeth as anchorage. Although these teeth were failing, we kept them in the short term to use them to help extrude the anterior maxillary teeth. We've also treated the lower anterior teeth, stabilized those and splintered them, and you can see how the orthodontics is used to sort of bring all the maxillary tissues coronally. Then we extract the teeth and we place our provisional bridge immediately on the implants. We're using an implant on the left as a retention and the tooth on the right, and we're going to just sit the bridge on the healing abutment. So one implant and a tooth for retention, and then obviously it's a fixed provisional which is sitting and supported on the healing abutments. That's another subject we won't need to discuss right now. And then we augment the soft tissues, follow the same protocol, placing our 8 implants in the maxilla in the areas that we normally would, central, canine, first premolar and first molar, and we skip the laterals, and we place our augmentation material. We graft the lateral incisors with the bone substitute to maintain the volume of the sockets, and of course placing our implants palatally. Same protocols that we've been discussing all this time, augmenting with the bone substitute material, placing our connective tissue graft. In this case we also carried out a frenectomy because you can see the very low frenum, and we tented all the tissues coronally to try and help everything to stay stable. This is the healing. Looks pretty ugly after the first couple of weeks, but this is quite normal in these cases. And then we see as it progresses, the healing continue, and we finally finish up. We obviously skip a lot of details for the sake of time, but we finally finish up with our final restoration, which looks something like this. And you can see that we've really more or less reconstructed, almost completely successfully, not completely, but more or less reconstructed the soft tissue profile of the patient so that she can have a normal crown and bridge type outcome. And this is going to be very easy for her to maintain long term and clean, and from our point of view creates a simple restorative solution. The outcome for the patient, very nice. We've re-engineered tissue that's been lost, and you can see it really looking very, very a good outcome indeed. And I think this is really a great solution for these cases. It is a little time consuming. Obviously there's a cost element involved, and it's maybe not for every case, but I think there are some big advantages for those patients which are motivated and have the possibility to create these improved situations. Particularly when you evaluate the case as it started, look at the unilateral bone loss. It tends to be greater on one side, and you know that those cases are always much more difficult to manage over time. The only options really we have with this case is to extract everything, flatten the bone levels, and do an all on 6, all on 4, or all on 8 as you prefer, and end up with a result with prosthetic gingiva for sure, and more complicated hygiene and maintenance for the patient. Whereas if you see on the right side, we now have a situation with small units of crown and bridge work, very much easier for the patient to maintain and manage the hygiene procedures, over 8 Pontic designs and a simplified prosthetic outcome. So, and you see the same patient now after 1 year follow-up, showing just a close view of those anterior teeth and the stable gingival outline. So, finally, let's just recap those important steps, and you see the principles are the same whether we're dealing with multiple teeth or single teeth, and we want to follow those same principles, and we also see that those are the key principles, those 6 factors that we looked at the very beginning. Stable 3-dimensional volume of tissue, of bone rather, to have the correct position of our implant, having adequate soft tissue dimension, using the correct shape to our transmucosal components, and then managing the soft tissue with our provisionals and our final restoration being controlled. I hope you found these helpful and this little brief journey with me useful for your implant practice, and I thank you for taking the time to listen.